A very good afternoon to everybody. Belated International Happy Women's Day, but it is a Women's Day every day. We can try and do something good for women across the globe. So here is almost our second attempt today in a series of events and a series of webinar by Rudraksh Institute of Medical Sciences. Today's our session is going to continue our theme for this year of breaking the bias, and we've just tweaked it a little more and called it breaking the health bias. And we have very esteemed chairpersons and very esteemed faculties who are going to talk about sexual health. Something which is very important to talk about, but yet a taboo topic. And when we were discussing, myself and Dr. Chawla, should we do this, should we not do this? And I was like, we should talk more about it. And the first two names that popped up in my mind was, we did a conference in October, and I had met this very versatile Dr. Shital ma'am, and she was like, we should do something. I was like, yes ma'am, totally, if you are up for it. And I have my own mentor and teacher, Dr. Purvi ma'am, who's always been motivating me. Dhruvi, we have to work in this field. We are diabetologists, and I understand, but we can make a difference. So here I am, very thankful to both the faculties to agree to be talking on this very essential, pertinent topic today. Moving on, I am going to introduce my very first chairperson, Dr. Leena Dabhi ma'am. She is the HOD and Professor of the Medicine Department, AMC Met Medical College, LG Hospital. She's been a mentor and guide teacher to my partner, Dr. Chawla, and has been a guiding light to us when we set up our hospital over here in Panagar. So with that, I'm going to request Leena to introduce our first speaker, Dr. Purvi Chawla ma'am.
Thank you, Dhruvi. I hope I am audible.
Yes, ma'am, you are.
Yeah, Dr. Purvi Chawla ma'am. She is a consultant diabetologist and director of clinical research, Leena Diabetes Care, Diabetes and Beyond, and Mumbai Diabetes Research Center. The Bharatiya Arogya Nidhi Hospital, Mahavir Hospital, and ES Global Hospital. She is a part of SCOPE certification for management of obesity. She is also a sub-investigator for various global and national trials, and trainer and speaker for various diabetes courses and conferences. So I welcome Dr. Purvi without wasting any time.
Thank you so much, Chairperson, for that very kind introduction, and a great pleasure. And thank you to Dr. Dhruvi, Dr. Vipul, and the entire RIMS team for having me to speak with you all today about female sexual dysfunction. Like Dhruvi mentioned, and it's a great pleasure and pride to be sharing the dais again as a speaker with Dr. Shital Punjabi. I'm looking forward to hearing your views as well. And like Dhruvi mentioned, it's literally breaking the bias, because how many of us really talk about it, or how many patients have really come forth and talked to you about female sexual dysfunction, or the fact that they are maintaining a healthy sex life or not. So this is a taboo for sure, but a very important aspect of having a good quality of life, and even while living with diabetes and other non-communicable or other hormonal, it is very important to be able to maintain this, because an overall well-being defines the well-being of a woman, defines the well-being of the society at large, and we all know that. Right? So why should the center or the central person in the household optimal health? So with that, if the host can give me some sharing rights, I will start sharing my screen. Okay, I will request everyone to just mute so that we can have a seamless presentation. Can you see my slides? Now I'm going to put them in the presentation mode.
Yes, ma'am. Yes.
Great. So yeah, let us learn about it better, because this is taboo. We don't talk about it. We as physicians don't ask about it. Yes, we may be empathetic, but this is one aspect that we can't miss. So with that, well, what is sexual health, right? We should begin with the basics. And normal sexual health is a harmonious state of fulfillment with a physical, emotional, interpersonal, social, and spiritual sense of well-being. And sexuality covers not only the actual sexual activity, but even thoughts about sex or physical attributes and the desire for engaging in sexual activity. So all this defines sexual health. I will only request, I know there are a lot of, there's a lot mix of physicians as well as general audience. If you would prefer me, sometimes to speak in a different language, Dhruvi, please feel free to just butt in.
Yes, ma'am.
So while sexual well-being is positively associated with quality of life, we know that if the person maintains a good sexual health and life, then the quality of quality of life of that person is very good and optimal. But like every other aspect of life can be negatively impacted by type 2 diabetes if not controlled or not maintained, or blood sugar is not maintained. Sexual function, especially in females, is also something that can be badly or negatively impacted. So we know that there is a lot of interest in male sexual dysfunction, right? The males, we have covered a lot of ground in the male sexual dysfunction aspect, but who talks about women's health, and it's largely overlooked. But say 22 years ago, the International Society for the Study of Women's Sexual Health, which serves as a multidisciplinary international community and is dedicated to the advancement of study of female sexuality, has rekindled this interest. Right? Like today, Dhruvi and her colleagues have taken charge and initiative to increase this awareness amongst all of us. The same way 22 years ago, the International Society for the Study of Women's Sexual Health also took this initiative, and it has made a difference, because today we are talking about female sexual health on this platform as well. Yeah.
Ma'am, the slides aren't moving.
Oh.
Could you just try once again?
Yeah.
Yes, ma'am.
Can you enable the participant?
Yeah. Yes, ma'am. Just a minute.
Yeah. Sorry.
Purvi, ma'am, can you try once again?
Yes, I will. No, it just says host has disabled my screen sharing.
Give me a second, ma'am.
Sure. A big shout out to all the ladies who have joined in, and a happy International Women's Week. We started on a high, and I hope we end on a high as well.
Purvi, ma'am, I think you should be able to share the slides now. Yes, ma'am.
Now, can you see the second slide?
Ma'am, it's not yet in the slideshow.
Okay, I'm doing it once again. Now, can you see it?
Yeah.
Can you see it?
Yes, ma'am, I can. Oh, now we are moving to. Yes, we are on the second slide. Third now.
Great.
Yes, ma'am.
So now, after that background, we'll come to the definition of what female sexual dysfunction is, because, once we define the problem, then we can intervene, assess, test for it, and then decide how we want to go about managing it. So the WHO has defined FSD or female sexual dysfunction as the various ways in which a woman is unable to participate as she would do. I will request all others to.
Purvi ma'am, since you are the host, all the rights are with you. And I'm going to try and mute everybody.
Quick, Jenny. Quick, Jenny.
Can we please mute everyone?
Yes, ma'am. Ma'am, since you are the host,
I've tried to mute a lot of people, but I can't. Okay.
Yes, ma'am. You were able to do that. Sorry.
No problem. So, well, the WHO defines it as various ways in which a woman is unable to participate in a sexual relationship as she would like to. Well, desire, arousal, orgasm, the three principal stages of sexual response cycle are disturbed, and this is what amounts to female sexual dysfunction. And the Diagnostic and Statistical Manual of Mental Disorders, DSM, what we call as, has defined female sexual dysfunction, and DSM-5 has basically combined sexual desire as well as arousal disorders into one aspect, which is female sexual interest or arousal disorder, and the second category as vaginismus and dyspareunia into a genitopelvic pain or penetration disorder. Okay, so I think we can understand that broadly they have made two categories, arousal disorder and a penetration disorder. And all these components individually should last for at least 6 months for us to call it a proper or define it as a female sexual dysfunction. Anything which is less than 6 months, in their opinion, is just a transient phase. It's not a persistent sexual dysfunction. Okay, so that's an important point that every clinician needs to dissociate or understand or to come to the perfect diagnosis. So disturbances in sexual desire and psychophysiological changes in the sexual response cycle cause marked distress and interpersonal difficulty. That is absolutely a given at this point. We've understood that. If we break it into components, then there are 4 main elements of FSD. One is the hypoactive sexual desire disorder or HSDD. Now, why I'm specifying these components is because the management will change. Okay, so to understand which aspect of sexual dysfunction is in existence, we can manage the patient better. So, hypoactive sexual desire disorder, that's the commonest and maybe predominant type of sexual dysfunction in females, where there is aversion to either sexual intercourse or just reduced frequency and interest. The next common one is the female arousal disorder or FAD, inability to achieve arousal. And then you also have female orgasmic disorder, as the name explains, and sexual pain disorder, again as the name explains. Dyspareunia, vaginismus, all that comes into the pain disorder. So these are the 4 main components. Now let's also understand, this looks complicated, but it's not. It's just to understand that this female sexual response is not exactly a linear response. It's basically it's interdependent, and we must acknowledge that emotional intimacy, sexual stimuli, and relationship satisfaction, they affect the female sexual response overall. So just spontaneous sexual drive may lead to sexual stimuli or arousal, and they may be seeking out and being receptive to other stimuli also. But and all these are influenced by biological and psychological factors, which ultimately lead to arousal and sexual desire. And then there is emotional as well as physical satisfaction, further wanting emotional intimacy. So this is again it's a non-linear model to understand female sexual response, and let's understand the factors that impact it. Again, as far as causes of female sexual dysfunction, diabetes are manifold. Many different aspects seem to be affecting those affected with diabetes and causing reduced female sexual desire or function in them. First of all, the commonest is hyperglycemia, where there is reduction in there is dryness of the local area or the vagina, which results in poor lubrication, pain, and again increased frequency of genitourinary tract infections. Right, and when there is infection, there may be increase in urgency, frequency, the itching, burning, and all those symptoms, pain also in the pelvic and discomfort in the pelvic region. Again, vascular complications arising from atherosclerosis as well as vascular endothelial dysfunction. The same major pathophysiological elements that affect the heart and kidneys and everything else also affect the female sexual dysfunction, and that can lead to reduced blood supply to the genitourinary parts and again cause vascular complications or reduced sexual function. Neuropathy as well as neurological disorders, which are common in those with diabetes, especially with uncontrolled sugar, and neurological factors like stroke, epilepsy, or traumatic brain injury. Neuropathy can cause just the structural change of the female genitalia, and that can lead to resistance. Okay. Besides these factors, there may be depression. Diabetes and depression are very closely linked. Women with diabetes have a twofold higher chance of acquiring depression and may subsequently be engaged in increased alcohol intake or smoking. There may be self-image issues, relationship issues. All this may also lead to female sexual dysfunction. Socio-cultural factors are also important. Psychological factors like anxiety, stress, low self-esteem, all those can also, fear of rejection, the arranged marriage system where you don't really familiarize yourself with the spouse, or all those things can lead to female sexual dysfunction in those with diabetes like any other female, even without diabetes. But the important factor remains the hormonal, including the thyroid, hypothalamic pituitary disorders, PCOS or polycystic ovarian syndrome, and menopause. These are important phases or conditions in a woman's life where the hormonal disturbances can also lead to female sexual dysfunction, particularly low estrogen levels. So let's understand that estrogen is one of the main drivers of optimal sexual function in females, and anything that lowers the estrogen levels can affect not only the lubrication of vagina, but also just maybe a poor general condition, lethargy, loss of interest, fatigue, and depression. And androgen deficiency also may play a part in the pathophysiology of low libido in women. Is it really common? Yes, it's very common. Only thing is that we don't look for it. So, well, the global prevalence of sexual dysfunction in women, and we don't have a very close or controlled handle on the numbers in India, but it ranges from 20 to 80% globally. In fact, one of the systematic reviews just 4-5-6 years ago said it was more than 40%. Now that's quite a high number, especially in the premenopausal women. So, and that's the peak of sexual activity. So that's that's very dismal. 40-42% of the women, suffer from FSD, and we don't even talk about it. So again, it was found, especially in one of the studies with type 1 diabetes, that whenever the sugar control was very tight, especially with new devices like the insulin pumps, as compared to the other basal bolus injections that they were taking, the female sexual dysfunction seemed to improve. So it was indirect evidence that better sugar control definitely leads to improved sexual function in type 1 diabetes. Well, another very important driver besides the hormonal aspect is the depression and mental health status, which are strong predictors of female sexual function in or dysfunction in diabetic women. With that, the determinants of female sexual dysfunction in type 2 diabetes was again reviewed in this wonderful paper in 2010, published in 2010. And out of 600 type 2 diabetes women, where they completed a questionnaire with different aspects of sexual function, and they showed that longer your diabetes, or the older you are, or the more overweight or obese you are, and the presence of other cardiovascular dysfunction or other complications of diabetes make your sexual function worse. And in tandem were other drivers like metabolic syndrome or cirrhosis, depression, and even marital status. All these predicted the sexual with diabetes. Especially when women with diabetes have complications, say for example heart disease or kidney disease or peripheral neuropathy or even history of stroke, then they report very low sexual satisfaction, or they report very low frequency of sexual activity. So they may have either lower desire or even limitation of sexual activity by physical health as compared to those without neuropathy. So these are important aspects that we need to consider. Now, what are the symptoms and signs of FSD? Again, this is important because many of us women do not understand, even if we may be feeling something and we may be feeling like sharing it with somebody, we may not realize the importance of that, because we may not know that that actually means that there is a sexual dysfunction. So for example, if there is hyperactive sexual desire, decrease or loss of desire or the interest for sex completely, that is one of the major symptoms or signs of FSD. Inadequate lubrication or dryness before and even during intercourse, which can lead to a lot of pain and discomfort, are also symptoms of FSD. Inability to achieve orgasm because of pain or spasm is also the same, and inability to relax the vagina to allow intercourse at all, which is called as vaginismus, that is also a sign of FSD. And pain during intercourse, vulvodynia, which is called, also symptoms of FSD. And non-coital sexual pain disorder, where there may be non-coital sexual stimulation, and that may lead to recurrent and persistent genital pain. So all these are different signs of FSD. Now, for a clinician, it's very important to understand whether the patient is menopausal or not, whether the duration of the symptoms, because that 6-month period may be important to know whether it is really a persistent sexual dysfunction as such, or it's just a transient phase in the woman's life. And then again, to understand whether it is situational or generalized. Screening and diagnostic methods, like for every other thing, we take a thorough history. And of course, we need, for this particular aspect, like even all the mental health disorders, we always recommend that make the patient comfortable. You must take the permission from the patient that he or she wants to discuss this with you. Limit the information, specific suggestions, and indulge in intensive therapy. So that principle is very important, because we have to make the patient comfortable, take the patient into confidence, and then make the patient speak about the sexual health or function for the patient. So again, there are diaries like Satisfying Sexual Encounter, or SSE diaries, that can be maintained, where the patient can record their number of satisfactory sexual events or experiences. Again, if you see, this is a positive connotation rather than negative. Positive because we are asking the patient to note down the positive experiences rather than saying how many times the patient had pain and otherwise, which is also important to know, but this is a sort of a self-incentivizing activity. And then there are several, from the clinician's perspective, again, there are very validated questionnaires that have been developed. For example, the Female Sexual Function Index, which is the commonest that is used in research for various new drugs as well as for studying female sexual dysfunction, which is the FSFI. Then you have a brief index of sexual functioning for women, DISFW, Derogatis interview for sexual dysfunction, for sexual function, and the female sexual distress scale as well. So the principal components of the commonly used scale, which is FSFI, that includes different aspects of sexual function, for example, desire, arousal, lubrication, orgasm, satisfaction, and then pain. So this is the way you can approach sexual dysfunction in women. Now, selected women may also need to undergo thorough laboratory workup, for example, of the thyroid status or prolactin, SHBG, total testosterone, estradiol, free testosterone, etc. And history must definitely be complete, because you not only need to know the gynecological history or sexual history or other disease history, but there has to be a specific question with respect to psychiatric illness, birth control methods or birth control methods, and hormone therapy history as well. Besides general examination, there must be specific abdominal and gynecological examination also that must be done, and including ruling out local infections or genitourinary infections. So a gynecologist has to be involved along with a physician, diabetologist, or an endocrinologist. Several possible determinants of FSD include autonomic neuropathy, vaginitis, pelvic inflammatory diseases, urinary tract infections, female genital mutilation, etc. All these can be ruled out at the stage of history and examination itself. Now, the major goal of therapy should be to restore the sexual desire. Like I told you, hypoactive sexual desire disorder, which is HSDD, is the main component or the principal component of female sexual dysfunction, and other components may be arising out of that. So other FSD are frequently resolved when we aim at resolving the hypoactive sexual desire disorder. Treatment options, contributing factors must be understood, whether there are myths and misconceptions on sex, which can be very effectively treated with education, cognitive restructuring clarifications, all the negative emotions that may arise from interpersonal relationships or the social environment. Again, there can be desensitization or non-demand touching or even psychodynamic exploration. There may be performance anxiety, which may be resolved by making the patient focus on pleasurable sensations and positive fantasies. Body image concerns can be also resolved, and relationship factors which requires intensive couples therapy. But besides all this, the most important is a healthy diet, regular exercise, adequate sleep, quitting to smoke, and definitely moderation in alcohol intake. These are basic. This is the basic advice that we give. In addition to this, weight loss may definitely help, especially in overweight partners, and control of hypertension, blood sugars, and dyslipidemia are very, very important. ABC, A1C for sugars, blood pressure for B for blood pressure, and C for cholesterol. They are very important in managing these problems. So when you rule that out, then majority of the problems can be ruled out. And the components of psychosexual therapy I already talked to you about. You look at the contributing factors and then devise the treatment strategy along with. Very quickly in the next 5 minutes, I want to complete this so that we can move on to Dr. Shital's talk. A look from a subset from the Look Ahead study, which was looking at the evaluation of intensive lifestyle changes as compared to the control group, which was just given diabetes support and education. In 230 sexually active type 2 diabetes patients were studied. After 1 year, they found that among the women with female sexual dysfunction at baseline, those in the intensive lifestyle group reported greater improvements in their total FSFI scores as compared to and resolution of most of the components as compared to those who are in the control group. Adoption of healthy lifestyle may reduce the insulin resistance, even impact the endothelial dysfunction and oxidative stress positively, and all this together can help the patient with diabetes lead a very optimally fulfilling sexual life. Omega-3 fatty acids are also recommended because they can help with some of the perimenopausal and postmenopausal symptoms as well as improve in the libido. Many cases of FSD can be treated with simple interventions like just treating the underlying infection. The other commonest things, and I'm sure Dr. Shital will elaborate more on that, vaginal lubricants and moisturizers are helpful because they resolve the vaginal dryness in women, which is very common in the perimenopausal period, or those with hypoglycemia or who also complain of vaginal dryness or dyspareunia. There is limited evidence, but DHEA supplementation may improve the libido and well-being among especially the postmenopausal women. It provides a large precursor reservoir for the intracellular production of androgens and estrogens in the non-reproductive tissues, thus helping with well-being and sexual function. There's another drug which is available in Canada and US, flibanserin, which is a serotonin 1A receptor agonist and a serotonin 2A receptor antagonist. This is actually approved by US FDA for generalized acquired hyperactive sexual desire in premenopausal women. But of course, one has to be counseled very well for severe hypotension and syncope. And again, type 1 diabetic women may not be able to use the same. Again, we have several strategies for, say, sexual pain, low desire, low arousal, and orgasmic dysfunction, but I'm not going into the details. A lot of it includes hormonal therapy, but psychosexual counseling and therapy is a must along with. Again, we also need to approach it with respect to reduction in vaginal lubrication or resolving the genital infections, treating vulvodynia and dyspareunia and orgasmia and reduced libido. So all variety of drugs do exist, all have limited usage and limited evidence, but we know that off the record we still use some of them to get the complete benefit. So current treatments for HSDD or the hypoactive sexual desire dysfunction and their hypothetical mechanisms of action are all given here. But an important component, like I said, is psychosexual therapy or the cognitive treatment as well. All that helps in improving the neurotransmitter levels in the brain and may also contribute to improvement in the function. So further studies are needed to better understand occurrence of sexual dysfunction and the impact on the quality of life among women with diabetes, especially from the conservative societies, and to understand the role of newer DHEA supplementation that's available, the estrogen-androgen replacement that's available, and also flibanserin, which I told you is available in Canada. You must ask and of course listen, because I think that's when we make a difference as female physicians especially. We should have our own developed structured and friendly questionnaires based on the Indian environment rather than just using things from the West. But we must develop them and work up and treat a female patient coming of diabetes coming with sexual dysfunction complaints. Because ultimately every woman deserves the joy of her sexuality. With that, I end my presentation and I hand it over back to Dr. Dhruvi. Thank you again for a patient hearing.
Thank you so much, ma'am. Leena, ma'am, are you there?
Ma'am, sorry. Thank you, Leena, ma'am, for that kind information.
This is Purvi ma'am's introduction slide. At that point of time, there was so much of confusion going on, and I could not share it. And Leena ma'am was still very gracious enough to be able to invite you without the introductory slide. Purvi ma'am was so well known, and she knows you, and I guess Purvi ma'am also knows Leena ma'am. So thank you very much, Purvi ma'am, for being here with us and starting our session today on female sexuality. Thank you, ma'am, for making a difference for all of us women and trying to understand ourselves very well. Leena ma'am is here. Ma'am, would you like to say something,
Yes,
please?
that was a wonderful presentation, Dr. Purvi. Thank you for touching this very important topic, which is very less discussed.
Thank you so much for that very kind invitation and a wonderful platform as well.
Yeah, thank you.
Thank you, Leena ma'am. Thank you, Purvi ma'am. With that, we move on to our second session, and I would like to introduce our chairperson for the second session, Dr. Praful ma'am Panagar. She is a gynecologist and obstetrician. She has done her fetal medicine fellowship, and currently she is the AMA Ladies Club president for the tenure of 21 and 22. We've heard her numerous times talking and advocating about female well-being. She specializes and has a passion for adolescent health, menstrual hygiene, and she's delivered lots of talks on the radio, on the television, and has done so many work in terms of activism, in terms of doing better for women health. So with that, I'm going to request Praful ma'am to introduce our second speaker of today, Dr. Shital ma'am.
Thank you so much, Dr. Dhruvi. Good afternoon, everyone. Dr. Shital Punjabi, she delivered the talk today, Female Sexuality Health. Dr. Shital Punjabi, she is a gold medalist MD, IVF specialist from the USA. She has taken training from the IVF and embryology from the Cleveland from the USA, and founding director of the Shashwat IVF Hospital, and she is a founding director of the IVF department of the Motherhood, Women and Hospitality 2012. She is a founding trustee of the Shashwat Foundation 2014 and consultant cosmetic gynec expert of the Midas Touch Cosmetic Center 2015, organizing committee of the ISAR 2020. She is a dynamic personality and all. She is visiting faculty of the national and international conference at the Bangladesh, Pakistan, Sri Lanka, India. Lot of the lecture delivered by her. She is a Gujarat president of the medical cell of the Women and International Human Rights Protection at the Bureau, and she is an active member of the FOXY, IMA, IMS, and ISHAR and AIMS, and serving the more than 5,000 childless couple in the term of the strongest, and conducted a lot of the surgeries or laparoscopy surgeries is like that. And this is a treasurer at the Indian Society of the Assisted Reproductive Gujarat Chapter ISAR 2021, and she is a president of India Eastern USA Business Council of the WICCI and of the 2021. We invite Dr. Shital Punjabi for delivering the lecture, Female Sexuality. Most welcome, madam. Your platform is for you. Thank you so much.
Thank you, ma'am, so much for introducing Shital ma'am. Shital ma'am, give me 1 second till I make you the host and I'm able to, give over the controls over to you. Give me just a second. So Shital ma'am, it's a huge pleasure to have you with us on this platform today.
Thank you.
Technology really ditches me at the time when I wanted to work with me. Okay, I have been able to make you the host now, and I hope you'll be able to share the screen.
Yeah, thank you very much, Dr. Dhruvi, for conducting and hosting this webinar. really the topic which is very less talked about and really genuinely very highly required of, it's need of in our. And I really appreciate Dr. Praful for the elaborate introduction about me. I would just say that we all doctors are here like for our patients to contribute in their life. I would start with my screen sharing. It was a wonderful talk by Dr. Purvi, and like a lot of things about the disorder. The female sexual disorder is being discussed. We know that it is when a disorder is for more than 6 months, then it is considered disorder. So right now I'm talking about the female sexual health. So in absence of disorder, what is it that a female passes through, and what is it that she's supposed to do, and why sex is important, and why there is a taboo, and what we, like being doctors, and we being female doctors, we being like game changers, right? What we can do, we'll talk about that. So I'll not touch those topics which already Dr. Purvi madam has discussed. We'll talk about the preventive aspects also. So as she has already told, like, all women deserve to enjoy a healthy sexual life. And everybody knows that, yes, this is very, very important. This was the definition given by Dr. Nicole Serino. And there are a lot of things talked about these in the Western literature, in the Western research institutes. And since last 22 years, it is being worked upon. And still, here in our country, very less we are talking about the female sex, female sexual activities, and female sexual health. When in a general language we talk about sex, it is the biological characteristics. But when we are talking about sex in general, it is the sexual activity or sexual inclination of the female or a male. So today we will talk about sexual activity, not a gender. So by definition, what is the health and what is the sexual health? So health is not only absence of the disease. Health, like sexual health, it's a central aspect of being human throughout life. As it is mentioned over here. Second very important thing. It is nature's way of continuing the reproduction and continuing the species. So nature has like tricked us into sexuality. Right, probably. Sexuality is experienced and expressed in thoughts, in fantasies, in desires, in beliefs, in values, in behaviors, in practices, in roles, in relationships. Very important. In Indian culture, for female, the sexuality is dependent on the relationship and how healthy is the relationship, how intimate the relations are. The score of like satisfaction is very high. While sexuality includes all of these dimensions, all of these dimensions are not experienced all the time and expressed all the time. Actually, I'm sorry to say that when I was like, when I started practicing cosmetic gynecology way back in 2014, the literature which I went through, it was showing that 87% of the female, let them be multiparous, the mother of 5 children, they have never experienced orgasm. It's only 14 to 17% of the lucky female across the whole of the world that they experience orgasm. And it is something which, by sensitization, by talking about it, by teaching all the females about right way of what is sex, probably all of them can enjoy, all 100% of the women can enjoy their sexual relationship. So, and it is influenced by, what are the factors? According to WHO, sexuality is influenced by the interaction of biological, psychological, social, economical, political, cultural, legal, historical, religious, very, very important for me Indians, and spiritual factors. All these factors are working on a female, and then female is expected to live a healthy life. Let us see how. So, sexual activity is a state of physical, emotional, mental, and social well-being. So, it's not just a dysfunction or absence of the disease or something. No, she should be healthy in all the ways. Physical sex, emotional sex, mental sex, and social well-being sex. So, for sexual health to be attained and maintained, the sexual activity, the sexual right of all the persons, whether it is female or male, must be respected, must be protected, and must be fulfilled. The female sexuality like it is like not only just physical or not only biochemical force, but it is like there are a lot of factors which are working on female sexuality. That is past based experiences, her expectations from her partner and from her life, her mental health and her emotional health, very very important, her interpersonal relationships. In India, as I told, it is nature's way of tricking us into reproducing. See, in India what happens, the females, they are usually passive. Usually they are just like it is their way of expressing their love towards their partners. Most of the females are into monogamous relationships and they do not have the variety, and they have a lot of pressures of the cultural and social. So forget about disorder. Only when somebody is suffering from disorder, maybe they would go and seek the help of a doctor. But in absence of disorder only, I think each and every single woman rather, in India needs a proper attention and proper sensitization. See, because of the culture, the female do not discuss, and it's not only in India, it's across all over the world that female do not talk about sex. So today, I really appreciate Dr. Dhruvi for breaking this glass ceiling and to really work on this subject, which is very very important. So these are few cardinal events. Madam has already discussed the desire, arousal, lubrication, penetration, and orgasm. What are the health benefits of sex? We are conditioned in such a way that sex अच्छी बात नहीं है, सेक्स की बात करना अच्छी बात नहीं है. अब बच्चे कहाँ से पैदा होंगे? So we are conditioned that this is something wrong or something which is morally low or something. But let us talk about the health benefits. So there are not only physiological health benefits, there are emotional health benefits. There is really a feeling of good. How? Let us see. So it lowers the blood pressure, it betters the immune system, there is better immune heart health, better self-esteem. Those females who have excellent sexual health, they are quite confident and they are super achievers in their life. There is decreased depression and anxiety, and one more thing, they have very reduced level of attention seeking because they are confident. There is a good quality of the libido when somebody is sexually healthy. When somebody is participating into healthy sex, very important. No, unhealthy sex we are not talking about. When somebody is into healthy sexual activity, there is release of dopamine, serotonin, neurotransmitters in the brain, and this has a good effect, and there is immediate natural pain relief. If a female has some muscular pain or something, she immediately gets a pain relief. And I tell you, being a gynecologist, working for more than 25 years in the gynecology, what I have seen is that the females who have unhealthy sexual life, they have a more incidence of getting a lot of muscular pains. आज यहाँ pain है, कल वहाँ pain है. She has a dissatisfaction towards her life. There are multiple reasons for that. We'll go into that. When sexual life is healthy, better sleep, better intimacy and closeness to the sexual partner, and overall less stress in both the ways, physiological and emotional. But because of all the social stigma, the females do not talk about sex, and मन ही मन में वो लोग परेशान होते हैं because for female it is intimate relationship with her sexual partner. That's why she is able to connect to the partner, and then as a part of her expression of love, she is indulging into sexual activity. So when a female doesn't get the intimate relationship with her partner, then she is emotionally shattered and her performance, her productivity reduces. So it is better to talk about sex, and we being doctors, what we can do, all the physicians out there, all the endocrinologists out there, all the gynecologists, what we should do is we should actively probe into the clinical history about her cultural practices, the social practices, how is the social environment in the family of that female, why she has some interpersonal relationship issues. When I'm treating the patients of infertility, we have to literally find out the clinical history. And most of the times when a female is sexually not healthy, she has an issue of the prolactin, and that results into like a chronic high level of the prolactin results into the dysfunction of the hypothalamo-pituitary ovarian axis, and then anovulation and other issues. And she comes to us, and then we find out that, oh, it is just this thing, and we don't have to use all the cutting edge latest technology to give her pregnancy, just taking care of that, and then she gets her pregnancy. So, and like this, during this corona time it happened that everybody were like they confined in their homes, and then a lot of people who had chronic anovulation and they conceived even without without going to any doctor. So there is a huge role of stress when a female is not sexually healthy and happy. And nowadays we see that a lot of females, they have dislike towards their partner. The partner is not hygienically proper, or his behavior is not appropriate, or he is maybe culturally still quite below the standards, or if his mouth is smiling, or if he is torturing the female, if the social and cultural factors are such, or maybe sometimes they are staying in a very small house or a confined house, and then the way we see in the Hindi movies कि बीच में सारे लोग सो रहे हैं और बीच में सिर्फ कर्टेन लगा दिया है. All these issues are there while the females, they do not opt for the sex with her partner. So that time my patients, they come up with the questions that how about I'm trying without a sexual partner, what can I do? And there are a lot of things nowadays because of the explosion of the knowledge and the Google and internet, a lot of techniques which are being shown, masturbation and sex toys and everything. So ultimately, it may not be the female may not get that intimate and emotional response from her partner when she is going for sex with her partner, but at least her bodily need, her anatomical need is being managed. So there are pros and cons. The bad part of the sex without partner is the foreplay part, which shows a lot of intimacy and which increases the chemistry between two partners. So that is being missed out. And second, emotional security. See, females, as we are discussing again and again, for female it is the security, the emotional security. कोई मेरा है, कोई मेरी केयर करता है, वो चीज़ के लिए most of the females are involved into the sexual activity with their partner. So here, if somebody is actually involved into sex without partner, they are missing out on these two major psychological things. Social stigma, जैसे हमने बात किया, not only in India but all across the world, it is actually considered as not to be talked about. But we, being healthcare practitioners, we are healthcare practitioners, and we have to be the change maker, and we need to really work on the female sexual activity. One more time, I would appreciate Dr. Dhruvi for taking this on. Our Indian culture and norms are such that we do not talk about this, and particularly when it is about pleasure. See, I am infertility specialist, right? When I am treating an infertility couple, I have to tell them. And then that time when I am talking to them about the time intercourse, when the lady is ovulating, yeah, that time she is fine. And even the husband is fine. And their family members are fine. They would come and they would ask us about the fertile period and everything. But when it is about pleasure, there are a lot of morality. And if a female has to be happy and then all the time moving around in the house with a lot of energy and she's always smiling and throwing the positive vibes, she has to be sexually healthy. Then only the whole of the family is healthy. We were talked about symptoms and signs by Dr. Purvi, so we are not going to go into detail about that. She already talked about FSA5. That is an objective scoring system. So when we find, being gynecologist or being a doctor, when we find that somebody has multiple aches and pains and this and that and everything, and when we do not find anything, पैथोलॉजी कहीं पे भी हमको ढूंढने से नहीं मिल रही है, तभी हमको ये FSFI क्वेश्चनर का यूज करना चाहिए. तो जिसमें जो मेजर कार्डिनल इवेंट्स है, उसके लिए हर एक तो क्वेश्चन है और उसका स्कोरिंग है, एंड इट गिव्स अस ऑब्जेक्टिव आइडिया. उसकी छोटी सी हम डिस्कशन कर लेंगे कि राइट फ्रॉम डिजायर, अराउजल, लुब्रिकेशन, ऑर्गेज्म, सेटिस्फेक्शन, पेन, उसमें क्या स्कोरिंग है जो 2 से शुरू करके 36 तक हो सकता है और उसका क्या इंपॉर्टेंस है. अकॉर्डिंगली वी कैन इंटरवीन द प्रोसेस ऑफ दैट क्रोनिक इलनेसेस. सो क्वेश्चन में 1-2 क्वेश्चन डिजायर के लिए है, जैसे लास्ट 4 वीक्स के अंदर आपका सेक्सुअल डिजायर कैसा था, देन उसमें डिग्री ऑफ सेटिस्फैक्शन कितना था, अराउजल कैसा था, वॉज इट डिफिकल्ट, हाउ वर यू कॉन्फिडेंट अबाउट इट और नॉट, वो अराउजल जो हुआ वो कितना आपके लिए अकॉर्डिंग टू यू स्कोर वॉज कैसा, अराउजल आपको 100% फील हो रहा था या थोड़ा लाइक कॉम्प्रोमाइज हुआ था, लाइक दैट. हाउ वर यू लुब्रिकेटेड, तो लुब्रिकेशन हुआ तो कितना हुआ था, वॉज इट रियली गुड इन क्वांटिटी और नॉट, पूरी सेक्सुअल एक्टिविटी तक वो लुब्रिकेशन रहा था या नहीं रहा था. देन वो मेंटेन नहीं हुआ तो वो क्या बीच में लाइक वॉज देयर समथिंग विच वॉज लाइक आपका फोकस कहीं पे गया था या आपको कहीं पे पेन हुआ था या क्या था, वॉज देयर एनी मेल पार्टनर प्रॉब्लम, आपके मेल को ईडी या इजैकुलेटरी डिस्फंक्शन था या प्रीमैच्योर था, क्या था. तो दैट देन ऑर्गेज्म इज वेरी वेरी इंपॉर्टेंट. ऑर्गेज्म ऐसा वो ऐसी चीज बोला जाता है कि इफ समबडी हैज अ गुड 100% ऑर्गेज्म then she lives her life like anything. She is fully charged up all the time, and like those females who have only 40 to 70%, as I already discussed, but those lucky females, they have orgasm during every sexual intercourse. They are very lively and very positive. But those females who have the problem with the orgasm, they want orgasm, but they are not able to achieve. So there is like some level of the neurotransmitter problem and they are moving around with a lot of frustrations. So orgasm के लिए FSFI में बहुत सारे questions है कि आपका कैसा है orgasm, कैसी, उसके लिए आपको बहुत hard work करना पड़ा कि नहीं, how was the quality, how did you find the emotional intimacy with your partner. When I am asking this question to my patient, you know, उन लोगों के लिए तो ऐसा है कि मेरा पार्टनर मेरे साथ रहे और किसी और के सामने ना देखे, उसके लिए like this is required. So for her she is the second citizen always. 500 साल पुरानी जो बात है वही अभी कर रहे हैं कि मेरे हस्बैंड को खुश रखना है और वो भी क्यों रखना है, किसी और के सामने ना देखे. सो दैट इनसिक्योरिटी इतनी ज्यादा होती है फीमेल में कि शी कैन नॉट लीव हर लाइफ. फॉरगेट अबाउट दिस सेक्सुअल रिलेशनशिप एंड ऑर्गेज्म एंड एवरीथिंग. शी इज जस्ट लिविंग हर लाइफ जस्ट टू प्लीज हर लाइफ पार्टनर. Female in the Western countries, they have different issues, they have different problems. See, for that security, for that intimate relationship, for seeking the expression of love from their husband, they are not participating in sexual activity. For Western females, it is a bodily need, it is an anatomical need that they are going into the sexual relationship. So, जो एक डेटा है स्टडी का, उसमें मैंने देखा कि between the age of 25 to 29, ये इतना heroic statement लगेगा आप सबको कि the females in the Western countries between the age of 25 to 29, only 1.7% female have one partner, some 5 to 7% female have 2 to 4 partners, and more than 80% female have more than 10 partners. Imagine, right? So their demands, their desires, their aspirations are different than Indian. So for we Indian doctors, for we physicians and healthcare practitioners, it is very very important that the female should have 100% sexual healthy life. Now, what stops from having a good sexual activity is very very important thing is pain, which is usually because of the endometriosis or maybe a type of vaginal introitus or maybe vagina is dry, maybe the postmenopausal or something like that. Sometimes because of urinary tract infection, because of the fungal vaginitis, because of like unhealthy hygienic practices, so on and so forth. And all these things result into dyspareunia, that is pain during intercourse, and the female would avoid the penetrative vaginal intercourse. So FSFI score takes care of this pain part also. That pain is experienced at what time of the penetrative intercourse? Is it during penetration? Is it later on? So, and then there are like scorings from desire, arousal, lubrication, orgasm, satisfaction, and pain. And accordingly, objectively, we can decide that really this female needs some intervention, either medical or surgical. We'll talk about it. One more area in the female sexual health is contraception. When somebody is feared of that, oh, out of this sexual intercourse, if I conceive, then what? And then वो सोच में आता है, and then then switch off. She can, like, even if she is turned on, she gets switched off. So we like healthcare practitioners, we have to take care of this. Then the fear of getting infection. That's why the females stay away. So, like, if we can just tell them that all the sexually transmitted diseases, right from gonorrhea, syphilis, chlamydia, HPV, HIV, everything can be, like, you can prevent yourself getting this by using a barrier contraceptive and by healthy hygiene practices for you and for your life partner, for your sexual partner rather. So then, she can, like, safely, like, fully, she can express herself and have a healthy sexual life and orgasm. Here, one more thing which we can do for our patients is doing, like, sensitizing them about infections. Second, giving them the treatment for the infection. Third, giving them the preventive measures for not catching infection. Fourth, sensitizing them for pap test. And fifth, giving them the vaccines for the cervical cancer. So all these things can take care of this STI part. Dysfunction, we are talking much about it. Already Dr. Purvi has discussed almost everything which we need to talk about. So probably we will not go into much detail. This is a major issue which was discussed by World Association of Sexual Health. The body integrity, sexual safety, eroticism, gender, sexual orientation, emotional attachment and reproduction. We are, like, gynecologists are, like, mainly concentrating on reproduction, but we can be the first point of contact for all those females out there suffering out of their unhealthy sexual life and just being passive, right? So that's what we should be. Now what happens? We have lack of training, we have lack of tools, we have lack of time and lack of treatment options. And that's why we are not able to, come up for our patients. So maybe, like, as Dr. Dhruvi has started with the training and tools, probably, like, she'll come up in the next event. And we can definitely spend some time with those unlucky females who have never ever experienced the orgasm. And when we are practicing cosmetic gynecology, what we do is we beautify their outer their vulva and all, so they have a good like emotional attachment with their good looks. See, the females of the earlier generation, they were not even aware about their outer look also. But nowadays, the females are literate, educated, and they are, like, quite careful about how they look, and they have started taking care of their inner aspects also. So they are coming to us for their beautification. So vaginal beautification, then vaginal facial, and labial facial, and depigmentation, and everything. Like, a lot of people are coming to us for that cosmetic treatment. One more group of the females, they are sexually active because maybe they are, like, inclined towards someone, or maybe they want some support, and they are unmarried, and then they want to get married later on, and they really want to hide that they were sexually active. So they are coming to us for hymenoplasty. If we do that, then they are very happy. The third group of the people, like, they have like, out of their sexual act, they just delivered their child, and then after a normal vaginal birth, there is laceration of the vaginal mucosa and the vaginal muscle, and there is laxity of the vagina. And there is laxity, and then there is no friction out of the penetrative vaginal intercourse, and they do not have the sexual orgasm. They come down to us, and then we use some of the energy device like RF or laser or HIFU, and ultimately they get a good vaginal mucosal lubrication and collagenization, and then they have their happy and healthy penetrative vaginal intercourse. One more group of the patients who have, like, a real medical issue, that is perimenopausal group of the females. The sex is estrogen and androgen dependent, right? Other than the psychological factors, these are the main biochemical things. So as we approach the menopause, the estrogen level goes down, and there is vaginal lubrication problem, vaginal dryness problem, and there is atrophic vaginitis. So those females, even once they try for the penetrative intercourse, they have a lot of vaginal issues and vaginitis and infection and everything. So when we do either laser or RF or HIFU for their vaginal rejuvenation, and then they get cured of their vaginal issues. So then that couple, like the wife and the husband, both of them are happy. So this is what, like, we can do for their female sexual health. Midlife, as I was discussing, there are a lot of misconception, और सब ऐसे पकड़ के चलते हैं कि हाँ अभी तो मेनोपॉज आ गया अब गया. No, for female a healthy sexual life she can enjoy even at the age of 64. The data, global data is suggesting up to 64. Almost all the females can enjoy their happy and healthy sexual life. Even they are older than that, and if they want to enjoy, they can. Only thing is, if they can take care of their atrophic vaginitis part, then they can enjoy penetrative vaginal intercourse. But if they have the issues with vagina, at least other than penetrative vaginal intercourse, they can really involve into other sexual activities and they get pleasure about it and they can just move around with a lot of confidence. So they don't have to go around with the misconceptions. Second most important is genital urinary syndrome. Whatever I discussed about this vaginal dryness and vaginismus and then atrophic vaginitis, all these things are genital urinary syndrome, and that can be very well taken care of with the help of the psychotherapy, the clitoral therapy, the vaginal rejuvenation, and when required in judicious dose, the hormonal replacement therapy. For hypoactive sexual desire, I usually ask my patients to come with their husband, and then husband is taught. He is given training of what is precoital play, how like he can induce the sexual stimuli for her his life partner. The reason is the male, they do not require a stimuli from the partner for arousal, but for female, even if she wants the normal healthy sexual life, for her arousal, she needs a stimuli from her partner. So we need to train the husband for different sexual stimuli, and we have to train him into different erotic zones of the female. It is his duty to find out that from lips to nipple to clitoris, what exactly turns his life partner on. The medical disorder part is already talked about by Dr. Purva. The desire part, yes, it is already talked about, that frequency of the sexual thoughts, previous coital experience, and masturbation. These three things we have discussed. One most important thing, those females who have a good number of sexual thoughts, or who are into good sexual activity, they are being stamped as a morally low or something. So it's a cultural norm. There were our forefathers had created a system of discipline for that, and that's why we are programmed in such a way that we cannot talk about it. But it is a wrong thing, and that female suffers alone, and that is the reason why a lot of females have a lot of chronic issues which we stamp as psychological issues and like that. Only if she gets a good cuddle, a good intimate relationship, if not penetrative intercourse, but at least a good support and good intimate talk with her partner, then probably she would not suffer from any issues. So we have to literally delete that conditioning, and the females have to done. Some females have increased desire. Who are they? When somebody is suffering from mania, schizophrenia, or alcohol or marijuana, if somebody has frontal lobe tumor, some head injury, or temporal lobe epilepsy, then there are neurotransmitters which increase desire. Decreased desire, very, very important, is depression, thought disorder, disturbed interpersonal relationship, very important. Dislike of the partner drugs, hormonal imbalance. Hormonal imbalance very, very common for perimenopausal females. Lubrication, probably already discussed, but one more important thing, wrong timing and vaginal infection, which can be taken care of. A lot of measures can be taken for that. Penetration, the problems are usually anatomical, obstructive, hymenal pathology, there is vaginal pathology, malformation, very common, which can be treated very simply, and endometriosis, which is painful intercourse. In vaginismus, what happens? It is involuntary contraction of the outer one-third of the vagina during an attempt or anticipation of an attempt of sexual intercourse. Most of the couples who have vaginismus, like the female has vaginismus, they come to us, and then they are coming to us with the complaint of infertility. When we probe them, when we ask them the clinical history, we get to know that they have never practiced intercourse. Forget about infertility treatment. So we have to first train them into what is normal, healthy intercourse, right? And then we find out sometimes that it is a very narrow introitus, wherein a surgery can definitely help. But in absence of a narrow introitus, vaginismus is a psychological issue and neurological issue rather. And in that, the penile intercourse is impossible. And in that, we can do a lot of treatment, that is pain-producing condition ka correction karte hain. Phobia hota hai, almost it is because of some childhood or past-based confrontation about the sex. We can give them sensate focus exercise. Sometimes surgical therapy has some role when widening the coitus, introitus. And yes, nowadays when we are using Botox, what we do is along with the cognitive therapy, injection of the Botox in both the sides pelvic muscles, and then that automatic contraction of the muscles is prevented by Botox. Orgasm, now probably we will be coming to the end of the session as a lot of medical issues are already talked about, so we'll skip those slides. But orgasm is something जिसके लिए one of my patient had described कि मैडम orgasm ये चीज़ है कि जिसमें मैंने अगर 50 लाख का डायमंड का नेकलेस पहना है उससे मुझे ज़्यादा इसमें खुशी मिलती है. So what is it? It is an explosive cerebrally encoded neuromuscular response at the peak of sexual arousal of psychobiological stimuli, the pleasurable sensations of which are experienced in association with dispensable pelvic physiological concomitants. So it is not only psychological or neurotransmitter, it is the a rhythmic contraction of the pelvic floor muscles which gives the euphoria, the orgasm, the best of the best sensation for the female. So when any female is suffering from FSD, if that pain part in her brain or in her thinking, if that pain part can be replaced by giving her the biofeedback therapy and training her into getting orgasm every time, so pain will be shifted to pleasure and she would start enjoying her life. So the orgasm disorder, early, delayed, impaired, absent, it may be because of a lot of things, probably they are all being discussed, so I will not go into that. So last thing, that women have equal right to enjoy their sexual health. And for that, we have to break the bias. We physicians, we doctors, we have to stand for those females. And not only for our patients. I tell you, when I started practicing my cosmetic gynecology, I could see that even doctors, the female doctors, they are not talking about their sex or their sexual dysfunction or their low desire or their low arousal or their low lubrication or their interpersonal relationships. And then we started probing into positively asking about their patient, making them comfortable that yes, we can talk about it. So it is now our duty to be the game changer. As female have equal rights for sexual health, we have to give them freedom from all the myths. तब के टाइम में शायद जरूरी था, now not. Being in a monogamous relationship is important, but खुद के husband के साथ में having a sexual pleasure, it is not a crime. So that is one thing. वो कुछ जो programming हुआ था कि मेल के लिए ज़्यादातर ऐसे होता है कि like when they practice into this sex and then when they release the semen, तो अपनी एनर्जी कमाते हैं. No, it is not like that. This is bullshit. Science has not proven it. It is for focused mindfulness, probably. It is being taught, but probably we took it in some other way. From pain, we can definitely free the female from the physical pain by different ways and means. Menopause can be treated by all the gynecologists and endocrinologists by giving them the right treatment, if required laser or HIFU, with that hormone replacement therapy in a judicious way. Inhibitions can be broken by Dr. Dhruvi and other such specialists who will come up with this kind of sensitization sessions. And fear of pregnancy was there earlier, around 100 years back, when there were no good measures of contraception available, and every act of sexual relationship female used to conceive. But now the female have choice. They can use the contraception, and by chance if the contraception fails, they can go for either emergency contraception or maybe they can go for medical termination of pregnancy as well. So female doesn't have to be in the cage of all those norms and everything. They have to come out, they have to go for the healthy sexual life and enjoy their life. That's it. Thank you very much. Some therapeutic options are there, but probably it is all being discussed by Dr. Purva. So I would end my talk right now over here. I think everything is being taken care of by her. I really don't think, yes, Kegel exercise, we should, being a gynecologist, we can train the patients after their delivery for healthy pelvic floor muscles. G-spot augmentation, which is the for those females, those lucky females, they have orgasm, they experience orgasm, and they have found out that this is my G-spot. We cosmetic gynecologists help them for augmentation of the G-spot by this vaginal rejuvenation and using PRP or filler. Filler may be either fat filler or the synthetic filler. And we can even augment multiple spots. And in a single act of penetrative vaginal intercourse, those lucky females can have multiple orgasms. For male, it is one orgasm only, but for some few lucky females who have found out where the G-spot is, they can have multiple orgasms in a single act of sexual intercourse. The nitrous oxide donor and everything is being talked about, cognitive therapy talked about, treatment, all treatments are talked about. So thank you very much for taking on this subject and really making some difference, and together we can definitely do something for all the female doctors out there and for all the general population females, they have the right to enjoy their life. Thank you very much.
Thank you so much, ma'am. Praful ma'am wants to make a comment.
Thank you so very much, Dr. Shital Punjabi. You have complete discussion of the female sexual health. In India, there is a lot of taboos, myths, different type of the things are there. So we have to initiate in a different way. So we have to educate the female and give the awareness program lot over there, and we have live interaction with the female of our Indian also. So you have a very briefly and nicely explained everything in a day, from the starting of the ABC anatomy to the treatment part and the different type of the indexes. So thank you so much, Dr. Shital Punjabi. You have a great initiative, and Dr. Dhruvi also have a great initiation, and we all are the practicing gynec and all physicians together. We make our healthy and wealthy female of India. So thank you so much, Dr. Shital.
PPT design page.
Now I hand over the mic to the Dr. Dhruvi.
Thank you, ma'am. We open the diet for a little discussion, and I have my first question to Purvi ma'am. Purvi ma'am, as female physicians, there are so few female physicians who would be comfortable enough to initiate a talk on, asking question about sexual health to a female. Ma'am, what could be our leading questions as to when we want to bring the complaints out, or some people might not know whether they have any troubles or not. Ma'am, what could be our questions, or what should be our history-taking process for that, ma'am?
That's a great question, Dhruvi. I think that's where we need to break the bias. First of all, let's understand that it requires patience, it requires time, and it requires a little privacy for the patient. You can't have 3 assistants in the room, the nurse coming in and out, the receptionist coming in and out. In that kind of, and you being, sounding impatient, the patient will never ever talk to you about any of these kind of problems. So one has to make sure that one is making the patient feel comfortable. If you are even guessing that the patient does not look happy or seems mentally disturbed, or there seems some worry in the patient, then definitely probe for it. Even ask the patient to come another time or wait back till you can give more time once the OPD is over, so that you can address this question with the patient. And so that's the first thing about making the patient feel comfortable. The second most important thing is be very receptive. Once you have that kind of a rapport with the patient, then again that sharing or that openness will come, and the patient will come forward and share these personal details with you. Third thing, I ease into talking about, say a urinary tract infection, and then I try to bring the attention of the patient towards that functioning. ask leading questions about any burning or any pain, and then subtly probe into the sexual function as well. And the patient may, sometimes they may say, no, all is okay, and then you take that. Or the fact that you have taken the lead in asking that question to the patient already starts feeling comfortable, that the patient has a, listening ear, and even if the patient does not share that with you at that visit, will definitely come back to you. I think with respect to Dr. Shital, the patients may be upfront coming to her with that problem because they know that she has the ready solutions for that immediately. But a lot of our patients are not that aware or not that expressive about it, and they think it's taboo. Like she also mentioned in her talk, it's absolute taboo, or that guilt of not being, not to, we just accept it as it is rather than talk or intervene in that problem. So that comfort, rapport, close attentiveness, and then a leading question or two, starting from say urinary tract infection symptoms to then subtly going towards sexual function and pleasure is very important.
Thank you, ma'am. Thank you so much for being with us.
One survey is there. According to WHO, reproductive and sexual health, the global burden of the ill health of the woman is 20% and male have a 14%. They have some survey or all over globally. So there is in our India there is a violence. Wow, we say not violence against the woman. It is a very big project is going on in the south of the India, and it is awareness of that. Because of the violence, disturbance of this, some type of the mental torturing, it will be affect our the hormonal disturbances, neurotransmitter, neurological, and so the problems will start. And infertility, so many factors are related to the sexuality. Not only this, so we have to aware mainly our the ladies also, postmenopausal, perimenopausal. So they give the proper guidance to their generation, the new generation. So this is the message to have to convey to the our society also. Yeah, thank you.
Thank you, ma'am. Thank you, Purvi, ma'am. My next question is from one of the doctors. It's such a wonderful feeling when you... Purvi, ma'am, yes, wanted to say something.
I'm butting in. I just want to compliment Dr. Shital for that excellent overview on female sexual dysfunction. Your talk was coming through so well. So thank you. Great to meet, a fellow Gynec who's so, Gynec who's so dedicated to female sexual health. And it was wonderful sharing the dance with you. With that, unfortunately, I have to leave because I have another commitment. And thank you very much again, all of you, for having us. Thank you, Dhruvi.
Thank you.
Thank you, ma'am. Thank you so much.
Thank you so much, all.
I still have a couple of questions, Shital ma'am, if you're up for taking it.
Yeah, we can take for some 5 more minutes.
Thank you, sure. It was a pleasure actually, ma'am. Just ma'am, the reverb. Sorry, we are in the same room. We are using 2 different systems, and that's why there's a little echo. It was wonderful. We had almost 80 people registered and 83 participants, and we also had a couple of male doctors. And quite happily, I feel so content that people are interested to do and make a difference for us. There is a question which Shital ma'am has already answered in the chat box about a PRP treatment for vaginal rejuvenation, ma'am. Could you just elaborate a little bit if you are okay with it?
Yeah, so we have been using PRP. As PRP is used almost everywhere, right from hair to toe. PRP is platelet-rich plasma, and it has from the blood, like it is to be retrieved, and it is like full of lot of vascular endothelial growth factors, right? So when PRP is being used in the vaginal outer 1/3 of the vagina, see it is the outer 1/3 of the vagina has the lot of neuroreceptors for the sexual activity and for the orgasm. So when we inject that PRP, when somebody knows where is her G spot, we can inject the PRP just in the submucosa of vagina at that particular point. But if somebody is not aware that where exactly is her G spot, what we do is like across the whole of the circumference of the vagina in the outer 1.25 centimeter, we inject this PRP. And there is no downtime in that. Like, the moment like PRP is injected, it starts absorbing and it increases the vaginal mucosal vascularization. Then it increases the more of the collagenization. So, and the submucosa of the vagina becomes relatively more elastic. So, because of that, the female has a better the friction, kind of the happy, healthy friction during her penetrative vaginal intercourse. So it gives her heightened orgasm, and for her partner also, it becomes a little more tightening of the vagina, and because of the more vascularization, it is little more warmer environment, and second, more lubrication. So the husband appreciates it more basically. So when we do this PRP, this happens that the couple as a whole becomes very happy. So after, usually we offer this PRP for two group of the people. One is after delivery, when there is laxity of the vagina, and then they have friction. Already female has delivered and she has pain of the delivery, and then she has to take care of her newborn child, and every time in the midnight or daytime the child would get cranky and demand for her attention and for breastfeeding and all. So that time female is as such also for her desire and arousal, she is not okay, she is not healthy, and that time her husband demands from her, and she has that insecurity that my husband मेरे हाथ से चला जाएगा kind of a thing, right? वो insecurity होती है. So that time this PRP helps them. Only PRP doesn't help, but PRP with Kegel exercises and taking good care of her and sensitizing her about the erotic zones and sensitizing her partner into clitoral erotic zones takes care of the sexual health of that couple. So that's how this PRP works. One more thing we are using is the feelers, which we use for the beauty treatments. A lot of females go for enhancement of their lips, and also for that because hyaluronidase fillers are available. So that same filler can be injected at the G spot, and that gives her heightened sexual pleasure during her penetrative sexual intercourse. But this is only when her desire part is normal, her interpersonal relationship is good, her arousal part is good, she has a normal neurotransmitter activity, she doesn't have any psychological or neurological issue, then this helps. So when all those, there are two groups, as it was discussed by Dr. Purvi, that there is one group about arousal and desire, the other group is about the pain and the vaginismus and the local anatomical factors. So in anatomical factors, this helps a lot. Right? And it places in absence of any problem. For normal heightened sexual pleasure, this helps a lot. Probably I have taken care of all the aspects of PRP and the sexual health. Anything else?
Ma'am, I'll just take a minute and ask our audiences if they have any questions.
Yes.
We have a Dr. Mary ma'am from Hyderabad. She's one of our leading diabetologists and endos from. Hello, ma'am.
Hello. Can you hear me?
Yes,
Yeah,
ma'am.
okay. Excellent talks, and especially Dr. Shital, we learned so much from your talk. As a practicing diabetologist, yes, I have to probe into these questions when I meet my patients. But men will generally come and talk about, erectile dysfunctions. But women rarely. You have to, sort of probe. So I just want to know, as a physician, is there, things in terms of those who are grossly obese or those who are having problems with, having the activity itself because of limitations? What do you advise to them?
Weight loss. First and foremost is weight loss.
Yeah.
And second, because of suffering from obesity and diabetes, they have usually a problem of recurrent fungal vaginal infections, and if they can take care of that infection, and then they will have little less painful and disturbing penetrative intercourse, so then they would involve more into the healthy sexual penetrative intercourse, and that will help them to recover from a lot of other chronic psychological health ailments. So probably we can help them by that way.
Thank you so much.
Thank you, Mary ma'am. Shital ma'am, we have a question from Dr. Jayashree ma'am, Dr. Jayashree Sheikh. She is our gynecologist and my own gynecologist. I trust her like anybody. And she has a question: what could be a side effect of PRP?
Yeah, Dr. Jayashree Sheikh, she is a very good friend of mine as well. I cannot see her, but she is a very lovely lady. For PRP, in a way, like if we have done in the right setup with all the antiseptic measures and everything, then there are no side effects. But if we have not taken good care by injecting something, we may end up getting some local infection there. Second, patient may not get what she had expected as far as sexual pleasure is concerned, and then she may come up with a question. So like my practice is when I am counseling the patients for all this stuff, I usually take a video consent and I give them the facts and figures that this is what you can expect. It is not a magic wand that you will get like a. So वो लोग में usually क्या होता है, there are two types of the people. One is one who is never happy with her looks. She has a dysphoric disorder. So in that, whatever you do, she would have some problem. It's a psychological disorder. And second group of the people, they have, or maybe either their husband or as a couple, as a partner, they have seen some YouTube videos and all, or some pornography things, and then they want that ये दिखाते हैं ऐसा चाहिए, and then sometimes it is not possible. Because it's a complex thing, there are a lot of things involved in it. So then they cannot have 100% satisfaction. So these are other than that infection part, this is the major issue. If somebody has done PRP and they do not get that heightened orgasm or that experience, then they may come up with that issue. So these are the things.
Thank you, Shital. But nothing like a constriction at the site or something?
No, it never results into constriction.
Okay.
Few cases are
excellent talk, I must say.
Thank you. See, PRP in female is very, very safe, except a local infection max to max. But in male, few of the patients we have heard of, like in the literature, that PRP is injected in the penis of the husband for the ejaculatory dysfunction or heightened sexual orgasm and like that. And sometimes, if inadvertently, some material, when it is being used with local sometimes, so if it is inadvertently disturbing those major blood vessels, because for male penile erection, it is the blood vessels which are most important. So if those blood vessels are injured somewhere, then it may result into the bad necrosis or sometimes even gangrenous penile problems as well. So we have to train ourselves. Gynecologists, they never practice that, but for those who are practicing, they have to be very, very careful when they are treating the male ejaculatory dysfunction with this PRP or some other therapy. Yeah.
Any legal point of view, teenage girls, suppose they are humiliated by the persons of surrounding and they have some problem. So where they will go and what is the law of for this sexuality and all? I think so. Please highlight this.
For law and all, and for particularly for those who are unmarried and they have been in sexual activity, probably we'll have to inquire somebody who is practicing law. Yeah.
No, some the Article 377 IPS call for the maximum punishment of the life imprisonment. Sometimes they have sexual harassment and without any consent of the female. So there is a law made in India. and other law is government rape cases 375, and new law section is 376A, protection against the violence domestic. Sometimes such type of questions and such type of problem we have routinely. So we have to call and involve the administration and police and like this. So what is sometimes rape cases are there, like so many happens. The new generation, 23% is the adolescent girls. They usually tortured by the family members, sometimes the relatives, insects, sometimes the different type of person. They are going to the college, school, so and so. Because I am usually taking the lectures of the menstrual hygiene management, such and such. So there's a lot of things. So we have to highlight this also. You have rules and regulation. So we have to contact this one also and will involve. So such kind of situation will occur. So we have to call the police. Then we have to solve by own way. Yeah, we have to do something, written consent for this and that. So what will do? Dr. Shital, please highlight.
See, when it is about rape and all, it is absolutely a different dimension of the practice and beyond the perspective of today's discussion. And definitely, whatever you say, this is in a way like, I am learning this in a way for the first time. I have not been read the yeah. So we are working on the other aspects. So maybe for what you are suggesting right now for the rape and all, maybe we can have one more separate dedicated session to discuss about it, and probably you can throw more light on that. Such that we get sensitization about this particular topic. So I would request you to conduct one such webinar, or maybe like we can now, like Corona nahi hai, we can have some offline session.
Yeah, definitely we have
this thing.
Together we have with some IPS and the all gynec and some physician.
Yeah, great.
Together we'll, great idea. So we have to convey the message of our society in India also. Yeah. We have such type of things in our country. Okay, thank you so much.
Thank you.
Thank you, ma'am.
So, Dr. Dhruvi, we have now two
I think
sessions.
it has been a wonderful session. We've had a very productive and a very fruitful session when we are, able to rope in so many leading physicians, so many leading gynecologists, and pass on our message to not just doctors but also to the leaders of our society. We've had, so many participants from various different diverse cultures. We had 48 doctors, both males as well as females, and I see that we've had questions from the male strata more, and that makes me think that even the male doctors are quite pro females, and it is high time that we start making a dialogue in terms of awareness of these situations and awareness of our own sexuality. The more I guess we talk about it, the less maybe we ourselves will be less uncomfortable, if that's the word, and let's do something which can benefit. And there are a lot of things like you just elucidated that it exists, and a lot of us are not aware about the basic normal basic normal physiology of the sexuality of females. So let's talk about it more, educate ourselves, educate our patients, and bring it to light to people that sexual health and sexual well-being is not just for reproduction, it is also for a normal and a healthy pattern for females as well as the males. So let's work towards it more and more, and not just on today when we are talking about International Females Day celebration. Let's talk about it more often at more platforms and bring together the change that we are trying to bring. So with that, I'm going to thank you all for participating. Any take-home message, Dr. Praful ma'am, Dr. Shital ma'am, before we close?
From my side, take-home message is you are living once, live 100%. Dr. Praful.
As a female, we have our dignity, our identity. So sexuality is not a taboo and myth, and we openly live the life in a boldly, enoughly, मैं ही काफी हूँ, me enough, like a female. Thank you so much.
Thank you. Thank you.
Dr. Dhruvi, I would listen from you, your message.
Thank you so much. Thank you, everybody. And we've had people from all across India. Thank you, Mary ma'am. Thank you, Leena ma'am. Thank you, Praful ma'am, Shital ma'am, and of course, Purvi ma'am. Thank you to all the males who are supporting us to propagate our message. Thanks to our institute for allowing me to put forward this initiative, and may we all try and continue our efforts in the direction for a better sexual health of females. Thank you to all the attendees, to all the doctors who attended, to all the healthcare professionals, the nursing staff that attended. Thank you so much. Thank you, ma'am.
So much.
Thank you.
Bye-bye.
Bye-bye. Thank you so much, ma'am. Thank you.